Hello and welcome to everyone who's watching across the globe. Today marks our last episode of the season 2. And boy, trust me, the season just went by with so much fun and science. That really makes it so much more meaningful for us organizers to bring this to you guys. We've been going strong for 2 seasons. And now today is our season finale. And we're going to talk about a topic that's really close to a lot of our hearts, honestly, advanced cataract surgery. And to do the honors, honestly, we have an absolute stellar panelist to, take us through this. Introductions will be done very soon, so don't worry. But before we do that, we'll go ahead and introduce the Rising Star series itself. Well, let me tell you, people who are watching new for the first time, it's a 9-episode series, which brings about 1 rising star each episode and surrounded by 3 panelists. Look, I really meant when I said celebrities, because you can see them right here and you see them in all your big programs, the ASCRS, the Academy, and ESCRS. They all are there all the time. Also, Rising Stars is a very interactive series. So any audience member watching can throw out questions on our chat window on our website or on the YouTube channel. And I will be, along with Jen, passing on to the moderators all these questions. We're live on risingeyestars.com and our YouTube channel called Rising Stars in Ophthalmology. Well, the timings don't suit the global audience. So we also have the reruns of this playing on our website at all times. Also, watch out for our social media, Facebook, Twitter, LinkedIn, so that we release all these educational tips and snippets of all our episodes. I'd like to thank you guys personally for tuning in today. Thanks to sponsors for making this happen. And now I would love to call upon Jen Lowe, who can introduce my celebrity panelists and speakers. So Jen, over to you.
Thanks so much, Ashwin. It's always an honor to be part of this amazing series. And this is especially like our season finale. So season 2, like you said, Ashwin, it's hard to believe it's already almost over. So before I begin to introduce our panelists and our rising star, I would like to take a moment to thank our sponsors. For season 2, of course, they've been so helpful to us for the entire season. And without them, we wouldn't be able to host this educational show. So I'd like to thank Allergan and AbbVie Company, Alcon, Vices Therapeutics, Avellino, Dompe, Sun Ophthalmics, and Tarsus. And again, once again, thank you so much for your support. For tonight's episode, I'd like to especially thank Alcon Surgical, and they have a short video, I believe, to play.
I think all of us really love to share this with our patients. In the FDA pivotal trial, 99.2% of patients said they would have the same lens implanted again. This statistic was somewhat staggering to me when I heard it, but I can tell you this has been my personal experience as well.
That I'm truly able to deliver upon what I've been hoping to promise patients for a long, long time with prior technologies, in terms of truly distance, middle, near-range vision of high quality without compromise. The PanOptix has certainly simplified that whole discussion for me, where I don't really need to talk about trifocal, bifocal, diffractive, refractive. All the technology discussion kind of goes out the window, and we can truly focus on how do you want to see after we're all done.
Usually at the 1 week where I'll have the patient read on a near card, and they normally can read very small J1 plus. Then I show it to the family member who's sitting, back when we could have family in the rooms. I'll show it to the family member sitting over in the other chair who's got their thick glasses on. I'll say, your husband just read this with no glasses. And they look and they go, wow, that's unbelievable.
We're constantly evaluating our purchasing decisions on other people's insights. And to have that, for me to be able to say to my patient, well, you know what, there's a study that was done and 99.2% of patients said that they were satisfied, or, that speaks volumes. And I think that, ultimately patients want to know, do people like it? And is it safe? Do I, and all those things that, are the basic like check boxes. And the nice thing that I found in offering this even to this toughest population, the PhDs, the research folks, the engineers, is that when that population in my practice has been satisfied, it gives me even more confidence to recommend that lens to a broader category of patients.
Well, thank you again to Alcon Surgical. And now I'd like to share my screen and introduce our team for tonight. So let me get that going here. As discussed, we are in episode 9. And let me get started with introducing our first celebrity panelist, and she truly is an international celebrity, Professor Soon-Phaik Chee, also known as Prof. Chee, I've been told. So we're quite honored, and I cannot wait to hear her surgical experience. I've heard so many amazing stories about her and her surgical skills. She did do college at the Anglo-Chinese Junior College in Singapore, residency at the Singapore National Eye Center, a fellowship at the Royal College of Physicians and Surgeons in Edinburgh, and medical school at the National University of Singapore. She's currently the Distinguished Professor of Clinical Education in Ophthalmology in the Duke National University of Singapore Medical School, and she's a Senior Consultant of Ocular Inflammation and Immunology Service and the Cataract and Comprehensive Ophthalmology Service in Singapore. There is a fun fact about her, which she's offered to share, that she's an aspiring baker. So welcome, Prof. Chee, and thank you again tonight for sharing your expertise.
Thank you.
Next up, we also have an amazing celebrity panelist and surgeon, Dr. Nicole Fram, and she hails from California. She did college at UC San Diego, medical school at Thomas Jefferson University, residency at Wills Eye, and a fellowship at UCSF. She's currently the managing partner of Advanced Vision Care in Los Angeles. So thank you again, Dr. Fram, for joining us. She is also a clinical instructor at the Stein Eye Institute. And a fun fact about Nicole is she has a Master of Arts in Psychology. Oh, I didn't know that. Very, very cool. So hopefully she can lend us her expert psychological advice tonight, which is a huge part of eye care and medicine in general. So thank you again, Dr. Fram, for joining us. And last but not least, we have Dr. Thomas Samuelson. He did college at Concordia, medical school at University of Minnesota, residency at the University of South Florida, and fellowship at Wills Eye Hospital. He is also a specialist in glaucoma and anterior surgery, and did his anterior segment surgery, and did his he is also a founding partner, at the Minnesota Eye Consultant. So another big name there. And he's an adjunct professor at the University of Minnesota. Fun facts about Dr. Samuelson is he's a captain, or he was, maybe he is, I'm not sure, the college ice hockey team, and a participant in the NCAA Final Four for the ice hockey finals. So that's really amazing. I have to admit, I didn't know there were actual Final Four in ice hockey. So it's really cool. You have to share with us some stories, Dr. Samuelson. And so again, thank you as well, Dr. Samuelson, for joining us and sharing your expertise. And okay, so now that I've introduced our celebrity panelists, I would like to welcome the star of the show tonight, Dr. Michael Patterson, who, he went to college at Freed-Hardeman University, medical school at Virginia College, residency at the University of South Carolina, and he unfortunately could not qualify for a fellowship, but we know he's amazing. We know he could have qualified for a fellowship, but he actually went straight into an amazing practice, and is the managing partner of the Eye Centers of Tennessee. Some fun facts about Dr. Patterson is he once split 4 ricks of wood in under 2 hours. And I have to say, I don't know what a rick of wood is. Can you elaborate, Dr. Patterson, on a rick of wood?
I would say that you probably need to do some homework on wood splitting. That was with a wood maul, not a mechanical splitter. And
Okay.
a rick of wood is a standardized stack of wood that we use to know how much we can sell it for.
Okay. So is that a lot of wood, I guess, splitting under 2 hours? That's pretty. Okay, I'll take your word for it. That's a lot. He also reads one book every 2 weeks, and he is a lead singer and teaches the adult Bible class. So he is very well-rounded. And, we just have a couple photos here. We wanted you to share with us what these photos mean to you.
Oh, I guess this is a new opening to an office in my hometown. It's a new partner I brought in on the far right. He played football at University of Georgia, and they just won the national championship. We flew down there together, and that's my father that's in the Bugs Bunny tie. And I joined his practice 6 years ago. And then that's one of our state representatives that's a good friend of mine that's in the area. And this is just us launching a new practice a year and a half ago.
Yes, that's awesome. All right. And yes, I think this is also your father too. He has a really cool suit on.
Yes. This is a Bahamian suit that he bought somehow that folds up inside of a Ziploc bag, the whole thing.
Oh, wow. Cool. It's a Bahamian suit. That's awesome. Well, that's really amazing. Okay. So let me see here. Let me see if I can click.
I don't know where they got that.
Okay. I think these are the last set of photos. If you want to share a few words about this.
It's just more group photos of our practice. We're about team here. We're about family. Our whole practice is built on that. And down at the bottom is just presenting with Zeiss. And then on the far right is just me when we worked with SightPath Surgical and a Sight Sciences device that we placed here early on. We are pretty big in the glaucoma space as far as MIGS integration, as well as just advanced glaucoma surgery here.
Awesome. All right. Well, thank you again for sharing. And thank you again for presenting. So I will let you actually take over now, Dr. Patterson, and you're welcome to share your screen.
All right. Thank you so much, Jennifer, and thank you to Ashvin and Bill. And I'm just so thankful. I'm grateful, humbled to be here. I'm not really sure that I deserve to be on a Rising Star lecture series, but I feel honored and to close out the season. And so I appreciate the sponsors that allow this to happen. I'm appreciative to my family for letting me come up here to the office at night and do some work. And I appreciate to the panels, the celebrity panel that is willing to come on a panel with me that probably they're on pins and needles about what I'm going to talk about, because advances in cataract surgery is a pretty bland topic. And I thought, well, how am I going to make this interesting? And what am I going to do to show people some things that we do? And I thought I just need to keep this simple. And so, I go through lectures all the time, as you do as well, and we hear about the history of cataract surgery and how they did things and how we've progressed. And eventually you're just kind of like, yeah, we know they went through intracap, extra cap, they've got to phaco, now there's femto, and you kind of get tired of hearing the same old. So I thought, what can I give people that is basic, but will literally change the way you operate today? And I think today I'm going to give some points that I do in my practice that allows me to run a very high volume cataract practice. I have one operating room. And out of one operating room, we typically run 28 cases by 11 a.m. starting at 7:30. And we do that by team, by no extra steps, and the ultimate respect for the patient and efficiency. And efficiency is really, really important. And it's not about going fast. It's about doing things perfectly as quick as you can. But if you don't do it perfectly, you're not going to be efficient. It doesn't matter how quick it happens. And we're sometimes scared to talk about this. And I think tonight I'm going to kind of share some things and pearls, hopefully, that will give you maybe an insider track on some things you could change in your personal practice that will help you become more efficient and become a more advanced cataract surgeon, because it's doable. I'm not a fantastic cataract surgeon. There's many out there that can do this, but you have to know the skills to do it. You got to know the steps, the basic steps to put them together to make the complex look very simple. And so we can't do the same things over and over. If we keep doing over and over surgery, we're going to get the same results. And so you got to shadow other surgeons. Every single year, I try to go to at least one surgeon on vacation, and usually two, to sit in their OR, to listen, to learn. I'm going to see a pediatric ophthalmologist in October. I don't do pediatric surgery, but I need to get myself back and understand what exactly are they doing? How are they doing it? And I'm just going to learn for one day to try to figure it out. But I think that's an art that we've all gotten too busy. We're too worried about our own personal time, and we forget that we've got to be at other people's practices. We've got to learn from our friends and colleagues. And sometimes it's good to learn on YouTube, but it's actually a lot better to actually go to see the person, to sit down with them, to break bread, and to learn a little bit together. And so I think the last point here on just how are we going to become efficient before I start throwing out the tips that I'm going to give is, don't become complacent. It's really easy to come out of our training and be satisfied with where we're at surgically, satisfied where we're at with our business, satisfied where we're at with our family. But you've got to dig deep and you've got to push yourself to get to the next level every single day, because truly your patient's actual life depends on it. There's hardly any sense. They're more scared to lose than vision. And it's our job to finalize a way to get that better. And so let's go through some of these tips. I've got 7 tips tonight. And I'm going to tell you the way I do things on incision management. And you'll just watch some of these videos we'll play. And so why are people still using stabilizers? I can't figure out why they're doing that. We've done about 15,000 straight cases in my OR where I've never used a stabilizer, no matter how bad the patient looks, up, down, left, or right. And what you'll see here is we have two blades, one diamond side port. That side port is completely dull on the side. I can move the eye left, right, up, down. It does not matter. It won't cut at all. And then I use my main keratome to come straight in. This saves tremendous amounts of wasted time using stabilizers, having to use one incision, then put lidocaine or viscoelastic in. We don't use lidocaine on a majority of our cases. We do most things under oral anesthesia. And so as this plays, the key here is no matter if the patient's looking up, down, once you get the side port in, you're good, because this side port is totally dull. It doesn't matter if it's a Morgagnian cataract like this. People worry about the chamber collapsing. The chamber doesn't collapse because there's no fluid leaving the para. The para can't lose fluid because it's completely sealed by a dull side port. And so I want you to see this slow motion here. Just why are people using stabilizers? They use rings. They use forceps that causes subconjunctival hemorrhages. I can't really see what's the benefit of doing this. And so I go to you straight, Nicole. What is your preferred technique for incision management?
Well, that is a very slick technique. We can't afford diamonds in LA, surprisingly. But I basically make a paracentesis and I use just kind of a cut Wexel 180 degrees. And then I put my 0.12s, or actually my smooth straight tires, within that incision, and then I make my clear corneal incision. So it's the same idea of not grabbing the conj and not causing a lot of destabilization of the eye about using nothing. But I love your technique. That looks great.
Soon, do you have any difference on that?
Yeah, in Singapore, we're even worse off. We definitely don't have diamonds, especially when we work in a center with so many residents. We have like 100 doctors in our center. And so we use 15-degree disposable metal blades. So we also have very shallow anterior chambers in the Chinese patients that we deal with 80% of the time. So to have a blade in the eye while we're trying to figure out the other incision is kind of dangerous in some of our patients, except for perhaps the high myopes. So I just do my 15-degree blade entry for my side port, and then I like to fill up with some balanced salt solution to firm up the eye. And then I use a little Sinski that does not go in. It just hooks onto the edge so that I can create my main incision without actually touching the conjunctiva. But great technique.
Thanks. Tom, do you do anything where you're using no stabilizers?
I'm proud to say I do like Mike. I do just exactly what you just showed. I learned that from Steve Lane. I use my side port to stabilize, and it's just like you say, it's really helpful because a lot of times the patient starts to bellow a little bit when you first, bring them under the microscope, and then all you have to do is just engage that para with your left hand if you're a right-handed surgeon, and then you can rotate the eye down just like you say and make your incision. I think Soon brings up a good point, because the one time I'm really cautious about that technique is the very shallow anterior chamber, where you sometimes need to adequately deepen with viscoelastic before your primary incision. But that's pretty uncommon in my practice, and I do just like you do, Mike.
Yeah, I do want to bring up one point about the finances of this. I've actually ran these numbers exhaustively, and I have a spreadsheet of that to show what the cost is of a metal blade over the span of a year of 2,000 cases versus a diamond. And it's surprising for most people, as long as you take care of them, it's an actual much cheaper proposition to have a diamond blade. We only use 3. We only have 3 trays, period, for our whole OR. It actually surprisingly is not as expensive as people think, unless you're with a bunch of residents.
As long as you don't break them.
That's right. Yeah, you just don't want to break them, and you don't let people break them, or they bring you eggs or chickens to repay that if they break them. And so, tip number 2: move on to phaco chop. I just don't get why we're still doing divide and conquer. While I understand why we're teaching it, we need to. But phaco chop is more advanced, but it's more safe. It's more efficient. It rivals femto without question for energy usage. And yes, it's harder, but take the time to learn it. You have the time to learn it when you're out in practice. My new partner that came in, Andrew Johnson, I said, you are not going to continue your current technique. You're going to learn how to chop. It may take you 2 years, and that's okay. But we're going to go side by side, case by case, until you know how to do this. And so when I do phaco chop, I'm always surprised that people worry about how much energy is used compared to a femtosecond laser. This is just a regular standard case that I do the same thing every time. If I get a golden ring, I instantly take a hemisphere immediately. I use the Stellaris phaco platform. It's incredibly efficient. If I have a golden ring sign, I immediately do a hemisphere so that I can grab it out and move. If that shows me it's a little bit softer, maybe a 1+ NS cataract. However, if I get a dense cataract, like this case, for instance, where the lens is completely mobile in the bag, I just don't see why anyone is doing any sort of sculpting on these anymore. It's not safe. The amount of energy that's directed towards the cornea is quite dangerous for the cornea surgeons. But what I typically do is just bury it in and slowly, one piece at a time. There's no rush here. I'll take a little piece off and then I'll section it again. People think you have to have a phaco chop in 4 quadrants or 6 quadrants. You might have to have it in 16 quadrants. And you'll see here that I will continue to go slow and slow and slow until I have to, until I take any small piece out. And then I haven't used a Malyugin ring or an iris expanding device outside of a sutured lens case in over 6 years. And people think it's really dangerous. but that's not what our data shows. If you're using a Venturi or a fluid-based system, if you're doing phaco-chop, you can easily go under the iris and slowly manipulate pieces with your second instrument. The man upstairs gave us 2 hands. We should use them. He gave us 2 feet, and we should use those. And we can use our chopper to manipulate pieces by doing a phaco-chop technique. This is an absolutely absurdly small pupil that's very annoying throughout this case. But because of phaco-chop, you couldn't do this with divide and conquer whatsoever. I never even moved my phaco tip out of the middle of the case. I can reach out, chop, and pull each piece slowly and steadily without any complication of this. You can use your chopper as kind of a second instrument to make sure that the iris is displaced. And then you'll see here, I slowly take out the nuclear fragments. And you can't do this with divide and conquer. You can't even do it with stop and chop. And so I don't really see why we haven't moved on to this, but tip number 2 is move on to phaco-chop. And I'll just quickly go to one of you. Nicole, can you tell me what is your preferred technique for cataract removal and why?
Well, it all depends on the lens. I will say I do not operate through a small pupil like that. I find that maybe in your hands it's okay, but that's some danger to the iris and other issues. My preferred method depends on the lens density and the other factors that are going on. So I do femtosecond laser for shallow chambers, zonulopathy, dense lens. I do quick chop, stop and chop, horizontal chop, all depending. So I love having all of these things available, and it's what the lens is going to give you. I loved what you said about if you get a golden ring, picking up a heminucleus, especially if you have issues with zonulopathy, is key. So I'm all over the place.
That's great. I phaco flip a lot of soft cases too, but I think overall you got to get a technique that you're good at and that works for you in the practice. And depending on how people do surgery, I personally just love phaco-chop, and I think it's very underutilized. The Asker survey shows 10% of surgeons utilize it, which is shocking to me, considering the amount of energy used, which we track in our practice. Tip number 3, simplify your post-op drops. I haven't used post-op drops in about 4 years, 0. I just don't see the need for them. We have tracked our CME rate as well. While we're not an academic practice, we track all of our data. I have people that work for us that this is all they do. And but it helps our staff morale. It helps our patients' morale. We don't have staff getting phone calls. We don't have patients showing up at pharmacies wondering where their drops are. And then here's the kicker. The CME rate is much reduced with a sub-Tenon Kenalog. If you look at what we use in our practice, we use a moxifloxacin mixture with Solu-Cortef. Very few people use it. Solu-Cortef is totally clear. So it gives you a steroid in the eye without having a particulate in the vitreous cavity. And then I place a sub-Tenon triamcinolone. This way you can use something it's not a preservative. It's not something that has preservative free. You don't need it to. And it's very simple. Right at the end of the case, you don't have to put any punctal plug inserts or anything in the eye. It's very cost effective for your center. If you're working in an ambulatory surgery center, this is me just instilling the antibiotic steroid combination. I always go in the capsular bag. And then right at the end here, I'll just distract the globe just a little bit to go down and place the sub-Tenon mixture, 0.2 cc's of the triamcinolone. It's very easy. The patient doesn't feel it. We do everything under topical, just like most of y'all. And we do everything under mostly oral sedation. About 90% of patients are oral sedation in an ambulatory surgery center. So, Tom, why are we still stuck on postoperative drops?
Yeah, I think some of it's just the fear of if you get an endophthalmitis or something and you haven't used drops, are you potentially liable? And I think there's good data to suggest that if you give intracameral moxie, you're probably which is what we do. But I think there's some concern about if they got an infection, would they be exposed potentially? Quick question for you, Michael. I'm surprised that doesn't hurt, because I used to use subconjunctival injections, sub-Tenon injections with trabeculectomy, and it was always the most uncomfortable part of the procedure for patients. So I generally don't, but I like your concept of reducing the burden of postoperative drops. So that really, the patients don't complain about pain at the end there.
No, we do about 6,000 cases between 3 surgeons. We got this from Kaiser Permanente out in California. They did over like 300,000 cases of this, and they showed the same thing. It's a 0.2 cc dose. I literally do 40 of these a week, and I never hear anything.
Get more volume. So it may be the volume, because we certainly gave more than 0.2 cc's.
And a 30 gauge needle, right, Mike?
It's on a 27 gauge needle, and it's like you said, it's 0.2. We don't have postoperative spikes either because of this. Now, that's the difference, is if you start giving out a half cc or a cc, you're going to end up with a chance in rise in IOP, but 0.2 doesn't, and you don't need anything in the anterior chamber. We do it for ICLs. We do it for cataract surgery. We do it for MIG surgery. It's an unbelievable regimen, and it's quick, simple, cost-effective, and patients love it. Soon, do you have any differences in your postoperative regimen with drops?
Yeah, I mean, I'm standard, in approach. I give intracameral. Sometimes I give intracameral dexamethasone, especially when I do the patients with uveitis, so that they don't have to do very intensive eye drops. And in fact, I don't even give pre-op prophylaxis for some of my anterior uveitis cases. But generally, for the standard case, it would just be 3-hourly prednisolone acetate and then Vigamox 3-hourly. But, I've used 0.2 mm of Kenalog in patients with scleritis, as we use it for treatment. And I have seen pressure spikes. And I've had patients where at even 7 months after surgery, they still have a high pressure despite the 0.2 mils of Kenalog. So I'm rather cautious. Perhaps our patients are a little different. So, I mean, I don't mind dexamethasone in the eye intracamerally, but I generally do not give a subconch because I just worry about the pressure and, of course, about infection.
Perfect. I am 3 for 3 of causing a controversy, so I'm making progress. The key here is that you do not do this subconjunctivally. It's important. It's post-septal injection. As you notice, the needle goes all the way down. It's very important. This injection is going back towards where you're trying to get it, and that's back around the back of the retina for CME. The anterior chamber iritis almost always goes away with a little subtenon. And so it's really critical of a post-septal if you want to avoid the postoperative spike. Let's go to tip number 4. Let's see how much more controversy. I know one person's going to really be concerned. Why not reconsider silicone IOLs? Maybe you just like dysphotopsia. Maybe you like to manage that. That actually wouldn't surprise me, the way people push acrylic IOLs. What percent of your patients with an acrylic IOL have a negative dysphotopsia versus your silicone IOL patients that have a negative dysphotopsia? And is there really a pandemic of silicone oil usage in ophthalmology for your patients? So the fix for the negative dysphotopsia, if I understand it correctly, the fix is to often put a silicone IOL. So why not place it in the first place? Just a basic, simple steps of silicone IOL usage. First of all, the nice thing is it opens planar. The worst thing that can happen, and I purposely showed this video to show you that it even happens to me occasionally, is you have to tuck the haptic in. That's the worst thing that ever happens with this. And then you, most of the time, just insert the IOL and it goes in smoothly, quickly, and it's already ready to go. You can go right under the IOL with your IA. It takes no time. They don't scratch as easy. And you don't have this dysphotopsia problem. So, Nicole, you're one of the world experts in this. I'm certainly not. But why are we so worried about this rare oil placement compared to the impactful dysphotopsia? I mean, most of the patients with oil are not going to see 20/20.
Right. So, Mike, I mean, I love a silicone lens because of its ability to have a lower index of refraction and less likely to have positive dysphotopsia. But negative dysphotopsia, in my experience, can happen with any lens. In fact, in our series, we had about 20% that were silicone lenses. It's any in the bag lens placement. And it's, the illumination gap theory is the most common theory that's accepted right now, where some of the light rays hit posteriorly and get bent to the nasal retina and some of them miss. And then it creates this illumination gap. And really the treatment for negative dysphotopsia is to move the lens forward. So whether you're doing a sulcus lens, reverse optic capture, putting in a piggyback to scatter lights, or taking away the nasal capsule in some cases. It's really that movement of the lens forward that causes the illumination gap to miss that part of the nasal retina. But that being said, I do not worry about silicone oil placement. I fully agree with you that if you want to use the friendliest material, I have patients, this is where my psych degree comes in. I have patients and I'm talking to them and they're going after every detail. And I'm like, you know what? You're getting an LI61AO, right? You're getting a silicone 3-piece lens because I'm just going to start where I think we're going to end up with positive dysphotopsia.
Soon, do you have any comments about silicone versus acrylic here?
Yeah, I think our whole center stopped doing silicone lenses because when we analyzed our endophthalmitis and we published this in ophthalmology in 2003, we found that actually there was something like a 5-time increased risk when we implanted a silicone lens compared to an acrylic lens. So that's why we shifted.
What's your reason for the increase in endophthalmitis with the material? That's not known in other silicone inside the body. So I'm just curious.
I think it was also found in the ESCRS study that silicone IOLs were more associated with increased risk of endophthalmitis compared to acrylic lenses.
Interesting. You know, I don't put these in eyes with asteroid hyalosis. We do know that when you YAG those, there is a chance for precipitate on the back of the silicone IOL. So those people are ruled out. And obviously those with severe diabetic retinopathy that we are worried about retinal detachments. But I'm talking about routine cataract surgery here. I'm talking about basics because that's what we are. We're basic cataract surgeons. And I think that this IOL, again, it's economical for your patient and for your team. And B, as Nicole said, the most forgiving lens there is. These patients have often enhanced depth of focus of a diopter to a diopter and a half on the curve just by placing a silicone IOL in with the AO. Tom, do you guys use any silicone IOLs?
You know, Michael, it's a great topic because I was a silicone enthusiast. In fact, I resisted the conversion to acrylic. Ralph Chu and I, when Ralph was a fellow in our practice, we did a study comparing the biocompatibility of the later generation silicone and the early acrylic. And frankly, the silicone had better biocompatibility performance in complex eyes. All those eyes had glaucoma, a lot of them were on pilocarpine, most of them were exfoliation. But what made me change, and I do primarily use acrylic now, was the one-piece design. To me, I really like the one-piece design. I love the optic haptic interfaces, a much broader shoulder, and you get better separation, at least in my opinion, of the anterior and posterior leaflet. And so that's what caused me to change, not the material, but more the design. I like the one-piece designs. I will use 3-piece, and I don't hesitate to use silicone on cases where I want a 3-piece. But my go-to lens on routine cases is generally one-piece design.
Yeah, and not most people probably watching this don't live in a center as big as the 3 panelists. They live in one like mine that's small, tiny, and they don't have ancillary IOLs for any usage. And so one of the nice things about the 3-piece silicone to start with, Tom, at least for me, is if I do have a complication, it's really nice that it can go straight in the sulcus and be optic captured very quickly without having to be concerned that you may need to take the patient back the next week or something. So in some aspects, I do appreciate having an ability to have a flexible, adaptable lens in that case. So let's go through tip number 5, combination surgeries. I don't know if this term is coined, but this is what I call it. And this is what I tell our staff. And this is what I tell my new partner. You know, it's never been a better time to invest in mutual fund ophthalmology in private practice. We are seeing a slew of people that have joined only one specialty, and they only do one thing, and they only keep their eye on one thing. And as we know, especially in the US, you know, it's just one stroke of the pen for the reimbursement to drop. And that's happened with cataract surgery. Some people lost 20% of their revenue because of that. And now is the time to make sure you're divested into many, many, many different procedures. We believe in that here. We take care of a broad-based amount of people with broad-based problems. It kind of shocks me, the amount of folks that claim that you cannot do glaucoma surgery with plastic surgery, with cataract surgery. You may not be able to do that in a level 1 trauma center area. But that's not where the majority of Americans all live. There's a lot of rural communities that need this, and it is capable in a comprehensive ophthalmology practice to be able to do this. So I urge you, consider MIGS. If you're not doing them, you should. There's all sorts of varieties. I'm not trying to tell you which one's the best one for you. That's up to you and in your hands, and you may need to try 10 of them to find which one you like. Consider DMEC, consider cornea surgery. I never thought I would do this in residency, never even did one. But one of the world experts came to my practice. He trained me. I went to his practice. I then trained with him. He then came back and trained on my own patients. And you can learn new things. If you're not using premium IOLs, you should be. There's options for patients they need. Not every patient's a good patient for them. We don't put in very many here because we try to talk most people out of them. But some people want them and some people need them. And so consider that. Consider cross-linking if you're not doing that. It saves somebody's keratoconus. Consider dry. There's so many things to consider to be a stronger practice, to have an advanced cataract practice. Yes, cataract surgery is important. Yes, cataract surgery is the number one go-to for most general ophthalmologists and most anterior segment surgeons. Even a cornea specialist or a glaucoma specialist probably do more cataracts than they do the other stuff. But consider the other stuff. We do about 500 bilateral plastic surgeries a year. And we pride ourselves in doing that. And we just simply offer it at the end of a cataract surgery. Are you bothered by your lids? If they say yes, they go down a questionnaire. If they're not, we move on. It's no big deal. There's no push, no shove, nothing. But I really strongly encourage you to get involved in combination surgery. Mutual Fund Ophthalmology is here. You have the ability to do it. You're capable of doing it, and you've been trained to do it. And so you should. Of course, I'm talking to a group of all fellowship trained people. And so I can only imagine the hair that's standing up on their back. But number 6, quit listening to those who don't practice what they preach. It's so disheartening when we go to conferences, and as we're new surgeons, I'm a very new surgeon, very young surgeon, have a ton to learn, ton to grow, and I'm learning so much tonight. But you got to make sure your surgeons that you're talking to practice what they preach. So many times that people get on podiums that do one case a week, one case a year, and then they're talking as if they're doing it every single day, all day, every day. Find surgeons who know efficiency. Find surgeons who understand the private practice medicine and cataract surgery. You don't have to be fellowship trained to perform at a high level. And as I just said, you may even pigeonhole yourself into being anything but the subspecialist if you decide to do a fellowship. So I preach, listen to those that are in the ground, running as hard as they can daily. That's what I've tried to do. The people that I've used as mentors, the Elizabeth Hughes, the Blake Williamsons, the people, Nicole has helped me, the people that are constantly working solid. Ashvin, I went over and got to watch him operate and see somebody that does it daily, day in, day out. Be careful who you're always listening to. They may not actually be doing much of what they're saying.
Oh, sorry.
Oh, go ahead, Nicole.
I really love this. I love this point. One of the things that it sparked in our practice is this idea of continuing to push yourself to learn. So every year we say we want to do at least 3 new procedures a year. And what that does is it pushes you into MIGS. It pushes you into other places that you may not have gone. So I really, really love the idea of really trying to not worry about being fellowship trained in it, but going to the people that are fellowship trained to say, I want to do MIGS like you. So how do I get on FOSS? What gonio prism do I use?
Tom, do you have any points from where you're at in Minnesota?
No, I agree completely, Michael. In fact, one of my favorite Hawaiian Eye moments ever was when you debated somebody in Glaucoma Day on MIGS and the comprehensive surgeon. I love that you gave a great argument, and I think you're spot on. I think, and from a glaucoma perspective, most of the world has mild to moderate disease. Most of the world doesn't need tube shunts, and and transscleral surgery. And so I encourage cataract surgeons to get comfortable doing canal surgery, and I know you are. It's a great point.
Well, and for our area, I had just this week, I did 2 Ahmed valves that we had patients that wouldn't have mattered what we'd have wanted. They wouldn't have traveled to 2 hours away to have surgery by a glaucoma surgeon that wouldn't have seen them for 3 months. So somebody has to do these cases, and people need to step up to the plate and know they can. You're going to deal with a little bit more heartaches than the average cataract surgery, but you can do it. Soon, you teach a lot of residents, it sounds like, and you're around a lot of residents, it sounds like. What are you encouraging your residents to do?
Well, currently in our center, we kind of stick to our subspecialty and we refer out to our colleagues who are specialized. So we don't really feel the pressure to do these cases ourselves because we know that our colleagues can do a better job. But I certainly agree, if you are in private practice, like many of the surgeons in Singapore who are in private practice, they would really cross their boundaries into something where they are not really fellowship trained in. And, it's like medical retina. It's so common now that you have to learn how to read OCTs and give injections. Otherwise, how do you survive out there? So I really think that it's important, especially if you're in the US, where perhaps you travel many miles to a doctor, unlike Singapore, which is only 30 km, across either way. Definitely, I would support what you are saying.
1 for 6 so far. Excellent. 1 for 6 on a unanimous approval. This is good. I didn't want more than 2, so maybe we'll get it on number 7. Tip number 7. And this is more because the talk is about advances in cataract surgery. This is something that should have been in everybody's repertoire. It should have been in everybody's playbook. It should have been your first page you go to when you wake up in the morning. You should wake up, no matter how tired are you, to say, how am I going to help my team today? What am I going to do to make this practice better and this staff better to make our team better? But wow, has it been lost. It's amazing to me how many surgeons are only on their cell phone. They're only on their Twitter. They're only on their live feed so that they can tell people how cool they are. They want to tell their wife that they did 60 surgeries when my wife doesn't even know I operate. No one cares. Your spouse doesn't care and your team doesn't care. They care about you working with them. They don't care that you're doing a new cool technique. So be an active player on the team. You're not any better than the janitor. You're not any better than the person that cleans the tables. The pandemic started and the only people that were getting the praise were the nurses. Well, what about the people that were cooking the food in the hospital, cleaning the toilets? Be the same thing as the surgeon. Too many surgeons stand and watch. Get off your cell phone, stay hyper-focused to the task at hand. You can help your staff turn over the OR every day. I turn over every single back table myself. Every single day, I open every single pair of gloves for every single case. I open every single phaco pack. You can too. You're capable. You're more capable than me. And you can just simply get your hands dirty and help out. Turn the phaco foot pedals, turn the microscope yourself. You're never too important to load an exam lane. When your clinic's busy during your cataract times and you're trying to see more patients, load your own exam lane. It's okay, actually, if you have to work up a patient every once in a while. It actually is probably good for us to occasionally have to work up a patient and say, yes, this is hard. Maybe you need to even go learn how to check in a patient at your front desk. I still know how to do that because my father made me. My father integrated in me that you are going to learn how to check in a person. You're going to learn how to sell a pair of glasses. You're going to learn how to dispense a pair of glasses. You're going to learn how to fit contacts because you are never going to be more important than anyone else in the office. You want to be a leader that people want to follow. And they don't want to follow you if you're not part of their team. And it's not your team, it's their team. It's our team. And so tip number 7 is the most important tip I could give you, which is be an active player on the team. And I'll open it up to the panel for any discussion on this part, whoever wants to say anything about the ability to get your team more efficient because you help out.
I love this. This is how, when you walk in the door and you can't complain that you're running behind. If you're not helping out. And it adds to the respect in the office for each other, that nobody's too good to do anything. And I think this is really, really, this is the best tip. Sorry. Definitely. I mean, this is really what it all comes down to. And even in the OR, I see people complaining about turnover time, and turnover time's too slow. And they're just standing there while everyone else is working. So this is really great stuff.
Yeah. A lot of surgeons need to eat and drink sodas a lot more than I do during the day. It's amazing how many times they need a break to get a drink or a bite to eat. So you don't have to do that. Tom, you got any comments? I see some thoughts rolling.
Yeah, I mean, I love it in concept. Do what you can to help out, whether it's picking stuff off the floor in the room and doing the different things. Our clinic and our OR are like right next to each other. So I'm off to clinic between cases. That's my between case time, mostly to see a second eye or to see a patient in clinic. But when I'm back and there's things to be done, I absolutely agree with you 100%. It's a great point, whether it's the OR or clinic.
I'll comment too. I think you're absolutely right. That's what I think I do too. Not everyone in our center would do it, but I transfer patients myself because we have our patients on trolley. I'll call patients myself and do the test myself. So I think it's absolutely important. If we, rather than complain about everything, we should be actually pulling strength. Great tip.
All right. Well, thank you so much for listening, Ashvin. That's all I've got. That's tips 1 through 7 for advances in cataract surgery. Thank you so much for inviting me, and I'm very honored to be a part of this.
Great job, Mike.
Mike, this was an absolutely stellar performance for a final series, for a final episode. Honestly speaking, there's so many, in the most literal sense, there were so many controversial points, but that is what really it takes to get ahead of the game. And that is why you are where you are. And that's why you're on this series as well. So rising stars, we talk about so many things. Most of them are borderline and probably crossing over the edge as well at times. And some of these topics which you spoke about today are so dear to so many of our hearts. Incision management, you spoke about phaco chop versus divide and conquer, which is the epitome of what we've been teaching all this while. And I never learned divide and conquer. This is my confession. I never learned divide and conquer, so I don't even know what that means. Similarly, I never did an ACIOL. I never did a suture fixator. I started with glued, and that's it. That's the end of it. And I get where you're coming from. The points where you talk about this on a podium and you'll probably not be faced with the right thing. So if I know how to cook Chinese food, I will say Chinese food is the best food in the world. But I don't know how to make Indian food. I'm still going to say Chinese food is best. That doesn't mean Indian food is not the best, right? It's just that those are some of those controversial topics which you just brought about. For example, the silicone oil, IOL, combination surgeries, and then that's very, very close to my heart because I don't completely comprehend what combination everybody should be doing it. That's not probably right because some people don't have the skill set to do it, and that's not wrong. But being and knowing about being a ophthalmologist is important. I think you do it to know what is the right and wrong, and then you can do what Dr. Chee was saying, refer it out if you're not at that level yet, and start taking in the easy cases in case you want to have a system to go about that method. Mentor choosing is so critical and so important. You hit the nail on the head. Don't do something that they're saying, do what they're doing. Being an active player is probably the most important point of them all. Just be present in the moment. Don't think about what you are and what you were. Be present at the moment. And that's probably some of the highlights of this episode itself. I'd love to hear Jen's thoughts on this as well. Very, very critical.
Well, I just have to say, Ashton, you're very lucky you've never placed an ACIOL. I'm glad you've spared that trauma. I'm happy for you. But no, I 100% agree. Michael, this has been an amazing, amazing talk. I love all your points, especially about helping out your team and, just being there and always, thinking about other people and just trying out new techniques too. It's just amazing. We all have to push ourselves to continuously learn. And that's what we're here for in all aspects of life. So I'm really glad that you are our finale.
Before I close out, I'd love to hear a few comments from Dr. Chee, Nicole, and Tom.
Okay, I think this has been a really amazing session, for someone who's many years a junior, just starting 6 years after joining the practice, just such great insights. And I think you really have a bright future ahead, Mike. Thanks very much.
Thank you.
Yeah, clearly, Michael, you made some great points, and anyone who does as many cases as you do and needs to be as efficient as you obviously are has a lot to teach and tell. And it was great to hear your points. Really enjoyed it.
So, Mike, I've known you from the start and the legacy of your practice, and I'm just beaming here with a lot of pride. And it's really the leadership that you've shown in this presentation of how to be a leader and how to support your team and be that managing partner now of this practice. You're probably making it better than ever. And I'm really proud of you.
Thanks.
Mike, any last comments from you on this? How was our participation towards you?
Well, I'm not sure that praise is deserved, but I'm so thankful to be a part of it. I grind just like everyone else does, and I'm grateful to have the opportunity to practice in an area that we can grow a practice that for people in rural communities and that don't have access to care. And I'm just thankful to be a part of able to do something that most people wouldn't want to do. And I appreciate the support tonight from the panel and from Jen, Ashvin, and Bill. Thanks a lot, guys.
Thank you very much, everybody, for patiently listening and taking part in our discussion here. We are extremely humbled and glad that you are able to support us and be here for this program. Remember, guys, audience people who are watching, our social media handles are on Instagram, Facebook, Twitter. All the episodes are present on our risingmystars.com website. Please don't forget to go back and watch. And I want to thank everybody because we will definitely be back for our season 3 starting August. So August 2022, we will come back for our season 3. Kudos to everybody who's been an organizing team as well. I want to thank Narayan and team. I want to thank Bill, Laura, especially, and Jen for being part of this wonderful series. Season 2 gets over. We are already kicking start discussions of season 3. We've got a lot of things finalized. So I hope to see you guys on the other side of this. Thank you so much. And good morning from here, good evening and good night from the US. So I'll see you guys in ASCRS.
Great job. Thank you.
All right. Bye-bye. Thank you.